Okay, good morning everybody. Thank you for coming out so early this morning for this symposium. Thank you for 3M for sponsoring this for this morning, and I can honestly tell you it's a really good session. We've got some excellent speakers and we're going to be looking at addressing the challenges that we find around skin integrity. So we've got 3 presentations this morning, and what we're going to do is we're going to listen to the presentations. We've got a few Slido questions for you, and then you're going to have plenty of time to talk to our speakers and ask lots of questions. So just before we start, everyone's in and sitting down, everyone's got their coffee. We just want to start with one question, just to give the speakers a bit of an idea about who we have in the audience. So on the screen you see a QR code. If you could use your phone just to get hold of the QR code. You don't have to download anything. It will come straight up on your phone, the question, and then we're just going to look at that first question. Everyone, I can see lots of phones out. It's very easy to do. Everyone done? Can we have the first question? It's coming. Lovely. So just for the first bit, we just want to find out a little bit about where you work. So, lots of people voting quickly. So it looks like we've got lots of people in lots of different areas, but we've got a good old split between acute hospital and people that work in the community, as well as research, education, other, and the care home sector. Brilliant, thank you. If you keep your phones out, because there's some questions that will follow on from the speakers after the talks. So, without any delay, I'm going to invite up our first speaker, who is Jacqui Fletcher. I'm sure a lot of you already know Jacqui, but at the moment she is the Senior Nurse Advisor for the Stop the Pressure programme with NHS England. She's also clinical lead for pressure ulcers with the National Wound Care Strategy, and also the editor of the Wounds UK Journal, and that doesn't half cover most things, but I welcome up Jacqui for her sessions.
Thank you, Fran. Good morning, everybody. And I need to put a disclaimer up saying that because this session is sponsored by 3M, I'm here this morning not in any of those roles, but in my independent nurse advisor capacity, and therefore the views I'll give you are mine and not those of NHS England or the National Wound Care Strategy. So I've been asked to talk to you today about assessing darker skin tones, or the challenges of assessing skin tones. And I'd just like to point you to both of these documents, both of which are freely available to download. This one on your left from Wounds UK and the one on the right from Wounds International. And much of what I will tell you about will be in there. So rather than you scribbling lots of notes, let's use the time to talk about what it is. And the other thing that I want to say is it's not just about pressure ulcers. Everybody automatically assumes that when we talk about assessing dark skin tones, that it's about pressure ulcers because we have that category that says non-blanching erythema. And to be fair, that's probably where it started from. I can remember in 2017 getting a query, just like a little email that said, "Ooh, is this quite right? You're using React to Red, and what about people who have darker skin tones?" And at the time being a little bit dismissive about it and thinking I'll go and read something and find out. And the more I read, the more I thought, ooh, maybe we do need to know a bit more. But what I also discovered was that it didn't seem to apply to any other wound. So we currently have a document that was launched just last year at Harrogate about red legs. We talk about the clinical signs of infection, which are heat, redness, pain, swelling and infection. Dermatitis we describe as redness and intertrigo. And also when you look at bruising, what does that look like on dark skin? So you might be familiar with a website called Mind the Gap, which looks at lots of medical conditions. There's not much actual skin care, not tissue viability, there's lots of other things, but it has a good description of lots of other things that can be involved. And I'd also like to recommend a paper that's been published this week in Wounds International, which I was fortunate enough to review, so I've managed to sneak a little bit of their data, but you can see this is the reference from it there. And for me, this is really interesting. So this is a team from Birmingham. Anybody who knows Birmingham will know it's quite a mixed race population in Birmingham. So they've got a quite mixed race population in terms of patients and staff. And the team were looking at the staff's confidence in assessing dark skin tones. And what you can clearly see is that if the staff member has black skin, they are a little bit more confident than if they have brown skin or white skin. But actually, the darker the patient's skin gets, the more their confidence drops. And that's quite sad, isn't it? That you're not confident in assessing your own skin tone. But what it did raise for me was I don't think we're very good at assessing skin anyway. I think we need to think about how we assess skin generically and then give people the skills to assess whatever it may be. And I get lots of pushback from people. I'm from Bedfordshire. I live in a small village in Bedfordshire. And I can remember thinking, and I know other people have said this to me when I've discussed this, but my population is just white. Why do I need to know this? And actually, you're exactly the people who do need to know this, because when you come across somebody with a different skin tone, you won't know what to do. Now, I was fortunate, I trained, and my first 3 wards were in Hackney, so it was a bit like working in Birmingham. I had a really mixed experience, and that actually gave me much better skills. So when we're looking at examining skin, we really need to think about not just using our eyes, but also looking at things like texture. Looking, is the skin dry? Is it moist? What else is happening there? And thinking about why that might be. So don't just go, oh, it's dry. Is that patient very dehydrated, systemically dehydrated? So is that an abnormal presentation? Ask about their skincare regimen and what that might be doing for them. Think about the skin texture. When we're thinking about pressure ulcers, we certainly do that feel for, is there inflammation? Is the tissue death already? And that's the same irrespective. So you should be doing those kind of things, thinking about what that's telling you in relation to what you think might be happening in the patient's history. You might also think about the temperature. So you know if that area is hot or hotter than the surrounding skin. And I had a really good question, because we've put about measuring heat somewhere else, about how do you know whether it's hotter? Well, you feel against the surrounding skin. And you also think, have you just turned the patient over? You know yourself that if you've been lied on that side, that is going to be a little bit warmer because it's been against the mattress. So give it a few minutes to equalise and to check the surrounding temperature. So if it's hot, it's inflammation. If it's cold, and you're not in a very cold room, that usually means the tissue is dying or dead, because it's ischemic, there's no blood supply to keep the heat there. And think about the skin colour. And the best word we can use is discoloured. So, with redness is still there. Please don't think we're saying don't use redness when you're describing to a patient with light skin and telling them what to look for. Don't feel you can't say red, because you give the language that's appropriate to the person you are dealing with. But discoloration is really important, because if you look at any one of us, whatever your base skin tone, your skin is slightly different colours across your body. So I'm quite brown at the minute. I was lucky to spend 4 days in Scotland and it didn't rain and it was beautiful sunshine. And we were out walking. But there's certain bits of me that are very pasty white. And you know yourself, your skin tone varies depending on the sun exposure, depending on what kind of activities you do. So try and compare parallel areas and you will start to see kind of what you're expecting. But one of the most important things is ask the patient. So ask them if they think the skin's a different colour or temperature. Ask them if they have any pain or discomfort or itch or numbness or tingling. All those things relate to inflammatory processes. And if we're looking for inflammatory diseases, which a lot of wounds have inflammation, then that is often your early warning signal or alarm. Start to recognise what different skin tones look like. So you can see here you've got a variation of lower limb pictures. So these ones at the top are from that first document. This one on the right is a different source. And look at that one, what I've put as a category 1. Now you might be thinking that's a very weird category 1, but this was given to me by a colleague whose mum's had a stroke and she constantly sits with her legs crossed. So she's got pressure from the other leg. Can you see where that's sitting on the front of her ankle, which is not where you'd normally expect a pressure ulcer, is it? But that's what that is. Look at this MASD. how much darker that is than the surrounding skin. So you can see there's a definite change in colour. And this category 2, I got so much grief for putting this in the pressure ulcer category poster, because if you read the international categorisation document, it says a category 2 is a blister filled with serous fluid. If it's a blood-filled blister, it's not a 2. And most people thought that was blood-filled. But that was my patient, and I de-roofed that blister, and that was serous fluid. So that's a serous-filled blister in somebody with black skin. So you really need to know the difference. And as a control measure, when I'm teaching about erythema, non-blanching erythema, what I typically do is use a picture or a little video of me. I normally do it on a train when I'm bored and I've been sat with my legs crossed, and I uncross my legs and think, oh, look at that big red mark, and I press it, and I think that'll be a good picture. So I got some colleagues to do exactly the same for me, and these are all what I would call people with brown skin. So you can see this first one here, the big one, you've got quite good redness. Whereas if you look at the other two that are slightly darker skinned, you can see the top one, you can just about see the red, and this darker skinned one, what you see is kind of a greyish colour. So we can't be absolute. We can't say if the skin looks like this, it's going to look like that. You just have to work with it and see what it looks like. Thinking about infection, so this is a hysterectomy wound. Hysterectomies don't normally just fall apart. They normally fall apart because they're infected. And you can see that's still bleeding. You can see the granulation tissue looks very friable. It's not right. So that wound is clearly infected. But if you look at the surrounding skin, where are the signs and symptoms? So you need to think a little bit more about what you're looking at. And be very aware of that colour change may be very different. And one of the big changes is that as wounds heal, as wounds scar, you may see a much lighter skin tone. So you can see both in this, there was a leg ulcer and a pressure ulcer, that very pink skin as the wound starts to heal. So I'm going to move on now and change track and talk to you a little bit about the impact of the current climate on skin integrity, particularly thinking about long waits and long lines. So quick brain change. Again, same slide, it's still me, still talking as me. Is this any surprise to anybody? Do you all watch the news, listen to the news, read the newspapers? So you all know that we are in a bit of a mess, would be being generous, wouldn't it, to say. But I really liked this diagram that I found from the Bristol Cable, because it started to pull together why we're in a mess. And actually, for me, this worked really well to think about. We know we've got a funding crisis, that's all over the news. We all know we've got a staffing crisis, that's all over the news. But it pulled together this systemic crisis, these things that we all take for granted about, why do we all do things differently? How many of you spend hours creating a form, and everybody else is using a form, but we've all got different ones? You know, how many of you are trying to change your risk assessment tool and it's not working, but somebody else just down the road's done it and it worked? What a waste of time. So there's lots of things in there about the systems and processes we have in the NHS that make things very difficult for us. But I wanted to use an example of how this impacts on a patient. And for me, falls are a really good example because falls are very common, particularly the older a person gets, and particularly if they're over 65. And we know that this is the most recent data I could find between 2017 and 2018, around 220,000 hospital admissions were attributable to falls. Now that's hospital admissions. Many of the patients who fall don't even make it to hospital. Paramedics don't always bring them in. They will check them over if they've not broken any bones, if they're not clearly bleeding, and if they seem okay, they'll get them back in the chair and leave them at home, because we haven't got any space for them in the hospital, have we? So if they can cope at home, they'll leave them at home. And about 2/3 of those patients were over 80. Does that surprise anybody at all? And thinking about what that's like for that person who falls, it must be quite shocking, mustn't it? Now, my mum had a fall. She was in her early 70s. She was in a ward and controlled place. She had an emergency call bell. And I think the contributing factors were she'd got a little bit older, so she stooped a bit, and she had a glass of gin. It was Sunday. She'd been round for dinner. We'd had a glass of wine with dinner, and she had a glass of gin when she went home. And she tripped on her nightie as she went in her bedroom. And she couldn't reach the call bell because she was on the floor with a broken hip and it was by the door. So she was incontinent because she was going to the toilet, that's where she was going. And she said to me, "I knew you'd be cross at me." Why would I be cross at you? But she lay there all night with a broken hip, wet, thinking that I was going to be cross at her because she hadn't pulled the call bell. So imagine what that's like. Imagine if you don't have anybody, you're lying there on the floor thinking, who's going to come and find me? How long am I going to be here? That must be shocking. And plus, once you've fallen, you're very worried about falling again, aren't you? So there are those kind of things that go with it. But let's think about what happens there. So this person's at home. They could lie there for a while before they even get somebody to make a phone call. A phone call is made for an ambulance. A person falling at home is not a priority. It's a category 3 call. So in East of England, which is my region, it takes on average 90 minutes, but in the literature it says it can take up to 2 hours for a category 3 call to be answered. So the person's been lied on the floor for however long, we don't know. Now you've made a phone call and they're still on the floor for up to another 2 hours. The ambulance come along, the paramedics assess them, they decide to take them into hospital. That can be a short journey. If you're in a rural area, it can be a long journey. They're on an ambulance stretcher. They get to the hospital in their ambulance. Can they get into A&E quickly? So that patient's now holding in the ambulance. So they can be in the ambulance for a couple of hours, can't they? On a very narrow stretcher that is not designed for people being on it for long. Because it's designed for dealing with trauma and for keeping spines stable and things like that. They make it into A&E. Hurrah, they're in A&E. Are they actually in a bed? Are they even in a bay? They could be in a corridor. And then they get into the ward. And if they get into the ward and we get them better, can we get them home again? Doesn't always work, does it? So think about that as a really good example of somebody who's just had a long lie and now we've got delays in the system. So we've got this low priority. They might not transfer to the hospital. And when I've spoken to paramedics and said, if you know that person's been on the floor for 3 hours, do you check their bottom? And they kind of say, no, we check to see if they're injured. Not all of them are trained to check the signs of the skin. They're getting better. They're realising it's in the curriculum. There's a couple of papers starting to be published about it. But it isn't what they do routinely. When they're in the ambulance, there is no pressure relief unless you've got a particularly enlightened ambulance service. So I know there's one of the southwest ambulances are looking at it. Some of the East of England guys are starting to look at it. And there's somebody up in the northeast looking at it as well. It's a very narrow surface because it's in a very small vehicle for all the kit they carry. So the chance of repositioning that patient, either to give them pressure relief or to inspect their skin, is quite low and quite difficult to do. They may be on a spinal board, or they may have some other kind of fracture system in place. If they've fallen and broken the hip, that makes it difficult as well. And there's nowhere to give them a drink or food in an ambulance, is there? So they kind of now becoming quite dehydrated. So if they've been on the floor all night, they're in an ambulance for however long, they can be quite dehydrated, and no toilet facilities. So it's a pad or whatever they've got available. We do have data on the number of pressure ulcers in A&E, and this is data from NHS Resolution, so that's the complaints people, looking at how long people spend in A&E following a fall. And you can see it's not an insubstantial time. This is quite a small cohort of patients, because these were patients who had sued. But if you apply that to everybody else, I'm sure it's not dissimilar. And if you look at the things that were not provided, so the blue is what was not provided to those patients, does that surprise you that they didn't get repositioning or a change of linen or pressure relieving aids or inspection of the pressure areas? It's not looking good for this patient already, is it? Once we get them into the wards, it's a busy environment. You know, they might have a trolley, not a bed for a while, so you're waiting to transfer them. So again, they can't get repositioned, you can't check the skin, and it might be difficult doing things like taking them to the toilet. They've got corridor nursing, there's a big impact on privacy and dignity, can't do skin inspections, and there are other challenges there in terms of getting that patient hydrated and well nourished. The patient whilst they're in hospital can become very deconditioned, and you know that. An elderly patient in hospital loses about 10% of muscle mass really quickly. That's really important in terms of returning to normality. If you want that patient to mobilise again, remember they're already petrified they're going to fall, and now every time they stand up they're a bit weak and wobbly, the legs give way beneath them. That is a problem. They're scared of falling because they have fallen, and we make them more scared because we say, don't get up, you might fall. We'll put a falls monitor under you. If you need to move, get the call bell. And we discourage them from moving, so they become more deconditioned, so they're more wobbly when they stand up, so they're more scared. The environment doesn't feel safe. How many of your elderly patients do you know, or your elderly family members, who walk around by holding on the back of the sofa, or the wall, or the strategically placed chair? And we put them in a hospital ward that the nearest next thing is like over there. So they've got no chance of setting off. And we used to have like randomly placed chairs on wards so that if you were feeling a bit wobbly or tired, you could sit down. Now you're not allowed to have clutter, are you? You're not allowed to have things. So they can't do that. We use equipment a lot to get people mobile, and it might be different to what they have at home, and they lose a lot of their confidence and they lose their continence because we give them pads. And I can't tell you how many patients or how many people have said to me, I've been told just to use my pad. And that's shocking, isn't it? And all this reduces their chance of going home. So if you think about skin integrity, they've been on inappropriate surfaces, we haven't been able to reposition them, we haven't been able to check the skin, they've had all this additional moisture, they've got reduced mobility and reduced independence. So a long line can be a cause of lots of problems relating to skin integrity, but particularly things like moisture-associated skin damage, and that long-term reduction in mobility and independence leads to pressure ulcers. And also leads to the risk of skin tears, because if they are lack confidence, they're more likely to be stuttery and staggery and bang themselves on furniture. So hopefully it's given you a good start, and I'm going to hand over to Robert now, who's going to tell you a little bit more about a practical approach to managing some of these problems. Thanks, Robert.
Good morning, everyone, and welcome again. So I'm going to talk about, well, really what I'm talking about here is the learning we had from COVID-19 ICU is what we're going to talk about, and how we've moved it on from COVID-19 finally and thankfully, and our experiences around that. So the title of the presentation is Deepening Your Awareness of Identifying Patients at Risk of Moisture-Associated Skin Damage, because we learned from COVID, and we learned from COVID ICU that actually MESD became the real challenge actually, and the challenge that we weren't really anticipating to see. So, and I apologise, yes, like Jacqui said, I'm independent, and I'm here in my role as independent nurse presenter today, and the data that I am presenting is actually data that we carried out at Royal Papworth Hospital during COVID-19 and thereafter, and was independent of 3M. So MESD and ICU. So there's risk factors to pressure ulcers. There's risk factors to MESD, medical device-related pressure ulcers. You'll be familiar with many of them, but the most common ones, of course, are in ICU is immobility and incontinence, and it's that incontinence that actually leads to the moisture-associated skin damage. Nutrition and antibiotics are big risk factors, because with nutrition in ICU, what you tend to see is NG feed in particular, which is a liquid feed. It will be continuous over 24 hours, stimulating the bowel, stimulating diarrhea and loose stool. And a lot of antibiotics for chest infection, pneumonia, and those antibiotics, of course, impact on gut bacteria, and that stimulates further loose stool diarrhea as well. Sedatives and analgesia, they're going to, of course, the sedatives are going to keep your patients, stop them from moving. They'll be immobile in bed, so they won't be getting pressure relief. And analgesia will stop them from feeling where the injury is, so the MESD or the pressure ulcer. Vasoactive drugs is huge in ICU as well. Vasoactive drugs there's many out there. The most common ones are called adrenaline and noradrenaline, which you have in your body anyway. But the problem with them is when you give them in vast quantities, it squeezes the blood supply, basically. So if you imagine the blood supply to your skin, the blood vessels are actually quite, they're narrow in diameter, but once you have these very potent drugs which are required for blood pressure, it makes them very narrow indeed. It constricts restricts them, and then you don't get blood supply to the skin, to the area under threat, and then that increases your risk of skin damage, pressure damage, and moisture-associated skin damage. And then your multidisciplinary team, skill mix and training standards. Again, what we need to bear in mind is it's not all about the nurses, what we delivered, the care we deliver. It involves the MDT, the medical ward round, dietitians. Having their involvement is hugely, hugely important in supporting the skin integrity of our patients. Another risk factor in skin injury, and I guess this, when we're looking at this, I'm talking about ICU, but you can actually generalise this to all areas. So we can see we've got community, you can apply this to residential, care in the home. The actual risk factors are very similar. So you have incontinence, immobility, lots of analgesia, even sedatives at home and in the community. And the skills that the staff providing this care have will vary. So it's a huge point to make. But the one we want to really hone in as well is length of stay, because with length of stay, we found before COVID-19 the length of stay in the ICU was actually relatively short. These patients in COVID-19 these patients, particularly on this ECMO machine, which is like when the ventilator fails, you have a bypass machine for the lungs, the length of stay is huge. And as you can imagine, the longer your length of stay, the more risk you have pressure ulcers, the more at risk you are at moisture-associated skin damage, medical device-related pressure ulcers. But you'll see in our data in a few moments what we present is, we present where the problem actually lies, which you'll see is actually, we found was MASD. And we'll present data showing you how we managed to break the link between pressure ulcer development and length of stay. So we carried out a study. It was published in Wounds UK in 2021. The study looked at all COVID-19 patients admitted to the ICU at Royal Papworth Hospital during the first COVID-19 surge, which was from March 2020 to July 20. It was subdivided into ECMO and non-ECMO patients. So your non-ECMO is your traditional ICU patient with ventilators and maybe not a ventilator. Then your ECMO is these really sick patients with a bypass in the bed supporting their lung function. We looked at rates of pressure ulcers, medical device-related pressure ulcers, and MASD. You can see much more detail in Wounds UK on the data that we captured. So what we found was, looking at the skin injury by type, this is all patients we looked at. So this is your general ICU patients and your ECMO, your very sick ECMO patients. What we found was, pressure ulcers, approximately a third of patients experienced a pressure ulcer. About a third of patients experienced medical device-related pressure ulcer, and then 56%, almost 6 out of 10 patients experienced moisture-associated skin damage. When we break it down and look at it in more detail, and we just look at the non-ECMO patients, the general ICU patients, what we found was, yes, again, a third of patients with pressure ulcers, medical device-related pressure ulcers, only 16%, because the length of stay in this group was a lot less, so they weren't exposed to the problems of medical devices lying on skin, on lips, and so on. And MASD, though, was more prevalent than pressure ulcers. Where it gets interesting is when you look at your ECMO patients, and I think it's important, you can use this to generalise to other patient groups as well, because patients who, whether it's on a ward, whether it's, as I said, in residential care home, at home, as long as you're sick, you're at risk, basically. And what we found here is very interesting. First of all, pressure ulcers, 33%. And if you go to the previous slide, it was 34%. So actually, length of stay and pressure ulcers, actually, we broke the link, and we'll go through why we managed to achieve that. Medical device-related pressure ulcers were quite high. The longer you stayed in hospital, in ICU, the greater the risk with your NG tubes and your ET tubes. But what came out, and this is why we put the effort into doing this study, was that almost 8 out of 10 patients experienced moisture-associated skin damage. It was really the dominant skin injury in COVID ICU. In terms of capturing that data, and this is it is important you do capture data because you need it for the clinical case and the business case to support the way forward with this. I thought they'd done a pretty amazing job considering how busy they were, the redeployments and so on. They managed to capture just over half of the pressure ulcer incidents on Datex, our reporting system. Our deep dive of all documentations found that 43% weren't, but the one that wasn't captured was MASD. The national standards, of course, are for reporting is MASD is reported, categories 2, 3s, 4s, DTIs, non-stageables. But MESD is one of them. But actually, it wasn't a surprise because of mass redeployment, you're looking at one nurse looking after 2 ECMO patients, one nurse looking after 3 patients, a doctor looking, a physio looking after these patients. So they weren't very familiar with reporting standards. But MESD was woefully under-reported. And it's important that you get those reports, of course, because it supports your case for how you manage these patients in the future. And the thing with MESD is, I'll be succinct really, it's pain. MESD pain in ICU is the challenge. Because with it, it has a huge impact on the psychological well-being of the patient, psychological recovery of the patient. It has a huge impact on the physical response to pain as well. It impacts on sleep and quality of life. If you're awake during the night because you have a sore MESD, when we want to rehab you during the day, actually we won't be able to do that because you're too tired. The impact on mobility, and this is where it gets, this is the key points we're trying to drive across about managing MESD, is that if you have moderate to severe MESD, it means it's going to be basically your bottom's going to be very sore. So when we want to actually sit you out in a chair, and sitting out in a chair, of course, in an ICU environment, but any environment is hugely important because it helps the diaphragm drops, the lungs drop, and then you can actually breathe, and then you can get off the ECMO, you can get off the ventilator quicker, you can get the trachea out quicker. You then don't need to be NG fed, so you don't have the stimulation from the NG causing diarrhea. So it's this negative cycle that we're trying to avoid, because actually what we're doing is we are facilitating rehabilitation of the patient. We're facilitating chest rehabilitation of that patient. So for what we done then was we gave it some thought, basically, our very, very tiny team. But so for COVID-19, that first surge, we saw that actually we didn't manage particularly well. Mass redeployment, including ourselves in ICU, so our team was pretty much obliterated. But through the data that we collected, we were able to represent the problem that we had. And then it was appreciated for the second COVID-19 surge in the winter that followed, that actually our team could be freed up to support care. And but we really did simplify it. What we went for basically was a single wash for these patients in ICU. So it was octennicin was the name of the wash, pH neutral, antimicrobial. We went for a single skin protectant. We went for Cavalon Advance and came up with the idea of on admission, and then it would be applied Mondays and Thursdays. All patients would get it to prevent and to treat MESD. Very simple message, but very effective message because it was easy to teach. We had a rolling team established for COVID-19 ICU surge. It was amazing. And there is why your link between the rate of pressure ulcer development and length of stay was broken, because they were able to reposition the patients, use the mattresses effectively. They weren't very good, though, at the essentials of care, such as hygiene. And that's why MESD problem was so big in the first COVID-19 surge, but was much better in the second. And then our mattresses. We use a very specific mattress on our ECMO high-risk patients. We use, well, it's called a Nimbus mattress. What it allows you to do is to deflate the cells under the main pressure points so that you can see light between, say, like the heel, for example, and the surface, mean you are getting total offloading. And we taught the turning team how to use this effectively, and we taught them how to manage moisture, use the Cavalon Advance and so on effectively going into the next surge. At the time, we called it the one show, but we could summarise it very simply as one method of skin hygiene, one long-acting skin protectant, which is our Cavalon Advance Mondays and Thursdays, one dressing regime, completely simplified it because most of these patients were restricted mobility, so we went to Inidine and foam non-adhesive was what we done. There was no adhesives available on the ICU to manage this because we wanted to prevent MRSA because that would be another problem on top of the MESD problem. And one dynamic mattress instruction leaflet, so our turning teams and also our bedside staff actually would know what they are, how to use it effectively. We had to get it through, we obviously had to get this through the system because there's an element of start-up expense to it. So involving with your leadership is very important, your decision makers, your sisters, ward sisters, managers and so on, your finance department for the case. And then procurement to make sure you can actually get the kit that you need through. And then the final mile is actually your storekeepers and getting in particular, getting Cavalon Advance from the store to the bedside to make sure it got applied was hugely important. So the upcoming, the pressure ulcer, national pressure ulcer day coming up is looking at making every contact count, and that's why looking at all these individual contacts we make it's so important that you do make every contact count. So then what we done in the second surge, when we got our, we had our rolling teams up and running, obviously, they were, at this point, they were very well trained in how to manage skin, how to deliver hygiene, how to use the skin protectants. And what we did then is we were now actually allowed to work in the unit in our role. And myself and my colleague went in and during this very short period, happened to be peak ECMO, actually peak COVID, we inspected the skin of every ECMO patient who was on the unit at that time. It was a massive 26 out of 65 beds that we had at the time. And the actual outcomes were really interesting. Because remember, we're not actually aiming to eliminate MASD. We're aiming to manage it so that it becomes intact or mild. Because if it's intact or mild, we can actually rehab the patient without pain. They can sit out, and you get all the benefits of sitting out. And from, as I said, from close to 80-90% of patients experiencing MASD, but quite severe MASD in the first COVID-19 surge, we managed to actually, in these very long-term patients, have a large number who attained intact skin. Another significant number had mild MASD, which is what we're targeting, and then only 2 actually had moderate and 2 had severe MASD in the audit of it. We did have to produce, obviously for the business case for it and the ongoing business case to get it outside of COVID. These are the numbers from 2021, but it stacks up really using the advanced skin protectant, using the wash and so on that we use, because ultimately what you're doing is you're reducing harm, the incident rates, and that's what's driving down your cost, and we simplified dressing use as well. Then finally we rolled out to the main hospital just over 6 months ago in September. We rolled out Simple Safety for Skin with the arrow there. I'll explain this because there's lots of colours and so on, but essentially before Simple Safety for Skin, which obviously does involve not just the skin protectant but the repositioning, the use of the mattresses effectively, what we saw in the last 6 months, and this is pretty much pretty bang up to date really, is that we saw a reduction in deep tissue injuries, category 2 pressure ulcers. We don't have many category 3s anyway, where it's the nature of the hospital that we are. And we saw an increase on category 1 pressure ulcers, which is very interesting because we think we're actually more early identification of the skin injuries, and that led to an increase in category 1s, but not actually deeper category 2s, category 3s and so on. I appreciate this is only 6 months of data. This may change over time. One bad quarter would change all of this. But however, so far so good rolling out to the wards. So we really have on the wards gone to the protocol of the Cavalon Advance, the repositioning schedules, and obviously the skin wash as well. So I think the discussion points from my perspective is like the hidden impact of MASD is pain. Managing that really will help with rehabbing your patients, their quality of life as well. You'll have opinions on whether we should have a wide wound formulary or restrictive wound formulary. We show the benefits of a restrictive wound formulary here in this work that we've done. The role of rolling teams, bring them back, it works, it's effective. And then of course reporting standards, because for us we go beyond the national standards, we report everything. And the reason we report everything is so that we can see effectiveness of the interventions such as this project on skin injury and harm. And finally, thank to everybody in Papworth Hospital, because all these people who went on to work in COVID ICU, and thank you for your attention.
Well, thank you to both our speakers. I think they've definitely been food for thought this morning. So if we just continue on, and we'll just ask you to participate a little bit with a couple of more Slido questions, and then we'll open that up for general discussion, or if you have any questions for our speakers. So if you can scan your QR code again if you need to, or if it's still open, that's great. I see a lot of people still scanning. Brilliant. So if we could have that first question, please. Brilliant. So, firstly, an open one. I know that the reporting of MASD came in around 2018, if I'm right. So it's really interesting that was before COVID. So asking this question, does your organisation report all MASD, is really interesting. It looks like the overall majority do report it. However, there's quite a few that don't still, and there's a few that don't know. Okay. Does anyone have any comments on that? The people that don't report it, does anyone want to put up their hand and discuss that? Somebody at the back. Roving mic to you. There we go. Here we are.
Hello, I'm Paul from East of England Ambulance Service. So obviously during the long waits, I will be catching up with you in a minute. Obviously, like during the long waits, we've experienced an increase of MASD. I was just wondering what would be some kind of intermediary for us to be able to kind of identify, report, and then address a multiple kind of like faceted issue between kind of culture for the ambulance service to be able to improve upon this, please?
Really good point. Jacqui, do you want to answer that one?
I think it's a real challenge, and we know there's a huge amount of work being done in the ambulance services. It's quite pocketed at the minute, but I know they're trying to spread it. And I think you're in a very difficult situation for any form of skin integrity because you are limited by the shape of your vehicle and the space in your vehicle and what products you can carry. So I know adding any additional product in is a thing of finding space, and if you put something in, you might have to take something out. It starts right at the beginning, doesn't it? If you go into the patient's home, putting it into that paramedic team's head to check the skin, not just for a wound, but if that person has been on the floor for a while, to ask those questions. Once they're in the ambulance, I really don't know what the answer is. You know, there must have been times you've faced that challenge that your patient needs the toilet, and what you're going to do when you're in a queue outside whichever hospital it is. You are really limited in how you manage that. But these are the things that you don't see talked about in the news. You get the big hoo-ha about how long the queue is. You don't get the hoo-ha about the fact that, you know, there was somebody's relative in there desperate to go to the toilet and two paramedics desperately trying to find a way to do something that gave that person dignity. But, you know, it can be quite painful needing the toilet if you're waiting a long time. I don't have an answer, Paul, but I think the more we start to talk about it, the more we can start to think about it. And, you know, it might be that you can have some wipes that protect the skin integrity. It might be that you can have some wipes that at least clean the patient if they know they've been incontinent. But it is how we make that work within the system that you guys work in.
And I'd like to add, just as an acute TVN, so working in the acute sector, whatever you write down during your skin inspection, whether it be at the patient's home or when you're en route, is absolutely invaluable to us as nurses when the patients are coming in, because if there's any documentation of any redness or damage, the nurses pick that up really quickly. And if the patient is acutely unwell on admission, when there are lots of different people coming at all angles, if you've already done that great skin inspection, it's really, really helpful to take things forward. So it's great that piece of work is coming up.
It used to be a bit of a joke, didn't it? Because people are obsessed about where patients get pressure ulcers, and the community will say it's not us, and the hospital say it's not us, and we used to just laugh and say I was always in the ambulance then. But that was more as a joke. But now you can see with the pressures you work under, it could quite well be in the ambulance, and that's not saying you deliver bad care. It's just saying the pressures that you work under, that patient is in a very vulnerable position on the wrong surface for a long time, and we have to acknowledge that. And as Fran said, anything you can document is really helpful, both in terms of investigations but also for quality improvement going forward, because the more data we have, and Rob mentioned data, you know, it helps, it really does help.
Absolutely. Oh, another question, of course.
Regarding underreporting on MSD, I think it's lack of awareness sometimes and misdiagnosis. They are reported as category 2 or category 3 pressure ulcers, and that happens very often.
I think you're absolutely right there. I think that's one of the hardest or the biggest challenges we face when we're dealing with patients that in the hospital where I work, because I think quite often they're either put down as moisture damage or MASD, or category 2, and it's really difficult to determine between those sometimes. So I think you're absolutely right, and reporting sometimes means that I think we have a bigger concentration on pressure ulcers, and sometimes MASD is given sort of a back foot. It's almost, on some wards that I go on, I think sometimes when we say, oh, it's MASD, I think you hear this, oh, thank goodness for that. So it's not pressure damage, and if it is pressure damage, it kicks off an awful lot of paperwork and different things, but actually that patient still has damage that we need to identify, and we need to treat there and then because of the differences and the pain and everything, as Robert said, that it causes. And that brings us quite quickly onto our next Slido question, which is... Oh, sorry, I beg your pardon. Sorry, Linda.
I just want to make a comment in regards to the ambulance service. Perhaps some of these communication apps with the photos, where you could fire forward any skin damage forward to the A&E department, so they were ready, and you'd prioritise a queue then, who had skin damage in the queue of the ambulance, and who you would prioritise and send help to if they had incontinence issues or whatever. But that's a fast and effective way of communication.
Absolutely, absolutely. Good idea. The next question on the Slido is, do we think we adequately recognise patients at greater risk of MASD, which of course we've just brought up, but we don't, so this will be an interesting one. Interesting, quite a few people say, oh, that drastically changed. So we do know that's an issue, and I think it's something that education, we just keep on plugging away at education to try and help people feel confidence to tell the difference between the two. But again, sometimes if we're honest, if I'm honest, I don't think it's about recognising if it's pressure or it's moisture. That is important, but the most important thing is putting something in place to stop it, to prevent it happening again, and to treat it for the patient. I think that's probably something that we know we need to do. Can we have the next question, please? So this is a bit more, it would be a little bit of typing for you. So what we're asking at the moment is we're just going to put up there some of your thoughts on what patients in your experience are at greater risk of MASD or IAD. So if you could type in, and then lots of your answers will come up. Interesting, we've got lots of things. Anyone, which is so true, anyone. Patients that are immobile, incontinent patients, patients with high BMIs, immobility, with loose stools, absolutely, elderly and the frail. What a lot of experience we have in this room. Those are amazing. Brilliant. I think what that shows us is that there are so many different patients that are at huge risk of MASD. And a lot of those risk factors are also risk factors for pressure damage, aren't they? And for lots of other skin damage. So that's really interesting. So if we go on to the next question, which again is another one where we want you to put in your experience, what are the impacts for MASD on the patient? Some of the words that you would choose for that. Pain, I think pain is definite, and Robert discussed that beautifully this morning about how much pain patients are in when they have the MASD. That's a really interesting one as well, isn't it? Embarrassment. I think Jacqui was talking about that, the embarrassment sometimes, and when you don't have that privacy and dignity, and patients that you've just been in, you've assisted them with hygiene, and you walk out of the bay in the hospital and unfortunately they've had incontinence again, and then they don't want to ask you because you've just been in there, so they'll sit for quite a while and are too embarrassed to tell anybody. Shame, depression. That's brilliant. Do either of you have any comments you want to make?
Fran, yeah, just
Please do.
Some excellent questions. I can recognise all or most of these. Just a quick response to the question about reporting, recognising. We've probably got on top of, in our hospital, as best we can with getting the word out in MASD. And hidden in the slide we had, in one of the slides, was actually about resource multipliers. So having actually other resources to do some elements, in our case, teaching. So we actually have the company, actually, we bring in the company, so in this case like 3M or Arjo Huntley, they come in once a month and they teach around the reporting standards and the management. And we see in our prevalence audits that we do every couple of months, that actually MESD, we're probably now capturing about 60 to 70%, which is huge. We were capturing very little of MESD reporting before, so you can do it, but I think you need to take advantage of your industry partners really, and other resources to come and help you as well. I think the embarrassment is absolutely huge. I mean, it's a huge. I think it's the person who you put it up. I think it's excellent because it's in such a personal part of the body, and patients may not wish to actually. They may just wish to get on it because of that. So I think that's hugely. It's well worth recognising the impact of that, and something we need to we need to drive home. But I'm going to get back to just simplifying everything as well around your reporting and around the strategies that you use is hugely important.
I think you made a good point, Fran, about the pain. You know yourself that you'll just get a patient comfortable and they'll be incontinent again. If they've already got denuded skin that is painful and then they get urine on top of that, that must be excruciatingly painful for them. So I think we very much underestimate the pain associated with this.
Absolutely, and I think it's really reassuring seeing all of those different things that you've all put in. So obviously it's known out there about how painful and how difficult it is to manage MASD. It's just that we've got to get on top of things, and simplifying anything that we can simplify in the NHS is always a good thing, I think, to make things easier for education as well. Can we have the next question up? This one is a little bit more focused on the darker skin tones question. So do you currently include information about assessment and management of darker skin tones within your education? Yes. Oh, brilliant. Lots of yeses. There's a few no's. Just revamped to include. Brilliant. A little. Well, there's a great one. No, but will now. That's a brilliant one. And I think this morning from Jacqui's presentation, what I've had very recently is a patient with darker skin that's healed, and it's a very, very light pink area, and it's in an area on the arm that can be seen quite readily. And he was asking me whether that will ever darken, to go back to a darker shade to blend in with the surrounding skin. And that's something that I hadn't actually come across anyone asking me before. I don't know, Jacqui, if you've got any... It won't, will it?
It will fade a little bit, as any scar does, because a new scar is always stronger colour. It will fade with time, but it will probably go to a more white colour than a pink.
Mm. So that's something that I think is really important to include in education, and we don't include that in our education at the moment. So that's definitely something that I'm going to take away from this morning and change my practice and go back and do a bit more. We've got a couple of minutes just for any other questions or comments anyone wants to make.
Fran, just whilst they're taking
Sorry.
photo, can I say, if anybody needs any photos for teaching, any of those slides that are mine, I will happily share them with anybody. So if you need them for education, just email me and I'll send you the slides.
It's really good. This one.
Oh, just on the scar management, you can easily tattoo them to improve cosmosis on patients with darker skin. So often you'll have a medical tattooist as part of your hospital for nipple reconstruction. They'll also take on scar management for darker skin pigmentation patients.
Brilliant. I did not know that. Thank you, Leanne. That's fabulous. I don't know if everyone else knew that, but that's really something that when you can go back to practice, you can investigate in your area. Thank you.
I was just thinking that it's important to make sure documentation when you've checked people with mixed race skin or dark skin, because I'm mixed race and I've got my children were when they were younger, they've got Mongolian blue spots. So they thought that they were pressure areas.
Okay.
But obviously they're not. But instead of like when English babies or they have the strawberry birthmarks, mine have all got like these Mongolian blue spots all over their bottoms. And the doctors actually thought they were pressure areas and things like that.
That's why it's important to talk to people. You know, I said, ask the patient what their normal is.
Yeah.
Because you know where you've got birthmarks or moles or whatever it may be. Or, you know, if it's a child, the family would know. So ask what is normal. And that's your baseline. Always what is normal.
And also it's the training and communication. And I think that's what sometimes we're lacking. The communication definitely between different members of staff on different shifts and things like that and handing over. And
it frustrates me that we have so few pictures of dark skin, and I think again that's people are scared of saying the right thing. People are scared of being seen to be racist because you're asking for that photograph. But actually we need to build our resource. We don't feel the same way about asking white patients for a picture of their wound. Why should it be any different? If you need a picture of a wound, you need a picture of a wound. And I just think we need to get better at it.
And also before we were saying about the patients feeling in pain, obviously if they've got a wound and pressure areas, but sometimes the patients won't say anything if they've just been washed and they've wet themselves again. One of embarrassment, and also they turn around and say, you're so short-staffed, I didn't want to pressurise you to do it again. So the wound's getting worse.
Yeah.
I think you're absolutely right. I think that happens quite frequently. I think it's easier in a hospital because there's more people walking past, and so they'll ask somebody different. But for patients in the community or in their own homes, that's very difficult, isn't it?
And you know, we've heard patients say, you've heard certain staff, or you'll just hear it randomly. I work on a ward at Hinchinbrook, and they've said, I've been told to wear my pad. That's unacceptable. I think that's absolutely disgusting.
I agree. It does happen.
And if I hear it, I'm the first to say something, even though someone might turn around and say, well, you shouldn't be doing it. But at the end of the day, that patient is mine for my shift. And if I hear it, it's not acceptable. No. Not at all.
It isn't. And also you have to remember that as nurses and all allied health professionals, we're the advocate for the patient. So absolutely that should be upmost in our thoughts when we're doing anything. So thank you so much for the questions and for this morning. I just got a couple of quick questions for you just on this before we end. How would you rate this session today? We're looking at stars. So, oh, lovely. That's brilliant, thank you. And then just another quick question, the last one, I promise, on this. Would you implement anything from the session back into clinical practice? I think we've already noted that there's going to be a lot of education on different skin tones going back to a lot of places, which is absolutely brilliant from this morning's thing. Definitely, yes. That's really, really positive to see. Thank you. So what I'd like to do again is to thank 3M for sponsoring this morning. I think it's been an absolutely brilliant session, and I think there's a lot of people that have got a lot out of it. So thank you very much. We couldn't do these sessions without sponsorship from industry. So thank you to 3M. Are we on for the video? Thank you to our speakers. Just very quickly before the 15-minute break before the first session, today is International Skin Tear Advisory Panel Awareness Day. That's quite difficult to say in the morning. And we've got a short video we just want to show you. It's only a minute or so before you go off and have a quick coffee before the first session starts. So I'll hand over. Have we got the video ready?
There's a skin injury that can affect people of any age at any time, and yet many healthcare professionals, patients and families aren't aware of how to prevent or treat it. Skin tears are traumatic wounds caused by a number of preventable circumstances, including blunt trauma, shear, friction, and even removal of a medical dressing. Despite their common occurrence, especially in older people, neonates and the chronically ill, skin tears remain understudied, and their impact on patient well-being is greatly underestimated. Therefore, the International Skin Tear Advisory Panel's mission is to promote awareness and understanding of these skin lesions across the healthcare spectrum. Many patients suffering from skin tears need a holistic approach to their care to ensure these wounds are properly managed and to implement a prevention program for the future. And with more studies to improve understanding, patients with skin tears can receive the attention and care they deserve. To learn more, visit our website www.skintears.org.